Let's see, I'm going to get started now. I feel like I gave everybody a few minutes. Hi, I'm Dr. Brian Greenwald. Thank you for joining us and being part of the Brain Injury Alliance of New Jersey's annual seminar. Before we get started, I'd like to remind everyone to enter your full name in the chat. This is our virtual sign-in sheet. If you're going to request CEUs, remember that you must attend this workshop in its entirety, complete the workshop evaluation, and if required by your discipline, complete a post-test. I'll be entering that link in the chat for your convenience. Zoom will provide a report of how long each of you stayed in the workshops. CEUs cannot be given if attendance is not verified. Questions are encouraged. Please enter the questions in the chat and they will be addressed at the end of the presentation. This workshop is the research presentation, and we have three presentations in this workshop. Our first one is going to be given by Dr. Ashley Kakanad, who's my fellow over at JFK Johnson Rehabilitation Institute. She completed her medical school training at the George Washington University and a residency in physical medicine and rehabilitation at Montefiore Medical Center, Albert Einstein College of Medicine. She has a particular interest in effective treatment models for patients with brain injuries who are transitioning from pediatric to adult care systems. And we'd like to welcome Dr. Kakanad to give her talk.
Thank you, Dr. Greenwald. Not sure if I'm able to share my screen. Oh, there we go. Okay. Just make sure I have the right one. All right. So we'll get started. So the title of this talk is Personal and Injury-Related Factors that Affect Successful Graduation in Transition Age Adolescents and Adults with Moderate to Severe TBI. And I'm Ashley Kakanat, as Dr. Greenwald mentioned. I'm the Brain Injury Fellow at JFK. So the purpose of this talk is to identify personal and injury-related factors that are associated with successful graduation in this late adolescent population who sustained moderate to severe TBI. And then we'll also introduce a predictive model for successful graduation in this population. So just some background, children and adolescents use academic performance in order to develop their identities and form their own self-concept, their own self-esteem, and all these factors are important for successful adulthood and adult success. After a traumatic brain injury, educational advancement can become difficult, not surprisingly due to the quality of TBIs that include cognitive dysfunction, social and emotional impairments as well. There's a wealth of information regarding guidelines for return to work and return to school in children who sustain TBI, but the specific population of the late adolescents is not as well parsed out in the research. So who are these people that I'm talking about, this transition age adolescent group? Various studies describe them differently, but generally it's around the age of 15 to 26 years old. And I'm sure you can all remember what you were like between 15 and 26 years old. You're quite unique and you're developing into the adult that you're trying to be now. So it's a very unique population. There's a lot of change going on, frontal lobe development, where adults or adolescents are starting to make their own executive decisions. They're making personal and professional and educational decisions and relationships that are important for successful adulthood. And again, there's a lack of specific data that deals with this population. So the purpose of our study was to identify predictors of high school, 2-year and 4-year college graduation in adolescents who sustain of this transition age who sustain a moderate to severe traumatic brain injury. And the way we did that was we used the TBI Model Systems database, which, as I'm sure most of you know, is a longitudinal database that takes information from all these various sites that you can see in this map. So if a patient sustains a TBI, they present to an acute rehab facility that is specific for TBI that's enrolled in this database, they are followed along for many years after their injury. So we looked at patients in this database who sustained a moderate to severe TBI between the ages of 16 and 24. And at the time of their injury, they were full-time enrollees in either high school or college. In order to be included into our data set, they had to have had consistent follow-up with the program with educational data that was available between or at the 1 year mark, the 2 year mark, and the 5 year follow-up mark. And anybody who didn't have that, all those educational data points were excluded from our set. Also excluded were anybody who had already obtained a bachelor's degree and were enrolled in higher education than a bachelor's degree, or anyone who is going for a GED diploma, or who was already enrolled in special education at the time of their injury. And the reasons that we excluded the GED and special education group is those have a lot more of other factors that come into play. And we were really looking at more of the mainstream education system. So the outcome measure we were looking for was successful graduation with either a high school diploma, an associate's degree, or a bachelor's degree within 5 years of the injury. So here you can see that we found about 969 subjects who were enrolled in or who fit our criteria, and they're dichotomized here with high schoolers on the left and college on the right. So the high school group is any student who was working towards a high school diploma at the time of their injury. They were generally around between 9 years and 11 years of education, which puts them around 10th grade. And then the college group was working towards either, they had already obtained a high school diploma and they were working towards either an associate's degree or a bachelor's degree at the time of their injury. And as you can see, there's a clear difference between the graduation rate overall in the high school group versus the college group. With the high school group can be more likely to graduate compared to the college group. So when we talk about what actually is the difference between, if we take all the patients here who on the left side here who were in the high school group, these graduates versus the non-graduates, what's the difference between those two groups? So some of the factors that stuck out as being different between the graduates versus the non-graduates, they differed by race, their level of education at the time of their injury, their FIM motor score at the time of discharge from acute rehab, and the causes of their injury. And when we looked further into that data and did more analysis on it, we found that the specific predictors that were statistically significant for successful graduation were identifying as white, having a higher level of education at the time of your injury, and having a higher FIM motor score at the time of discharge from acute rehab. If we move on to the college group, it's a little bit different. So how did the college graduates versus the college non-graduates differ? So again, they differed by race. They also differed by their cause of injury, just as the high school group did, and their FIM motor score. But they also differed by the history of their prior TBIs, so that it was a traumatic brain injury of any severity, as well as their living situation. So whether they're living, alone or with their parents, or in an assisted living or some sort of other situation. And again, when we look further into that data to see what actually was a significant predictor of successful graduation, we have the same top three here with identifying as white, having a higher education level at the time of the injury, and then having a higher FIM motor score at the time of discharge as well. But in addition, we've added in the higher FIM cognitive score as statistically significant for predicting a successful graduation in the college age group. So what can we decipher from all of this? So clearly there was a difference between the graduation rate of the high school group versus the college group. And part of that might be because the high school is already set up with a lot of structure involved in order to make sure students are moving through the system in order to receive their diploma, versus college, which is a little bit more self-motivated and less structured in that sense. In addition, about a third of our college sample had to be removed from our data set because they didn't have consistent follow-up at the 1, 2, and 5 year mark. So that alone is skewing the rate a little bit. So it's unclear whether that third that we didn't look at were actual graduates and we're just not including them in our data. In addition, one of the reasons that you might have a lower rate of college graduation is that there is a higher cognitive demand in college versus high school, which also correlates with the idea that, or the data that we see that a significant predictor of college graduation is their FIM cognitive scores. So some things to keep in mind, as I already mentioned, the education system varies significantly between high school and college. And then service delivery in those realms is also very different. So the structured delivery of various therapies and academic accommodations is, again, more structured and potentially easier to obtain in the education system in high school versus college. But in all realms, in all of education, it is still difficult to get assessed or attain those accommodations that might be necessary for to maintain or to gear students towards successful graduation. And in this population where people are transitioning from one age group to the next, potentially from pediatrics to adults, moving from high school to college, there are potential lapses in service delivery. And then that touches on also the medical service delivery, where, again, moving from pediatric population to an adult population and looking for adult providers who would follow up and continue communication with the education system is an area that is not very well structured, and it might be a room for improvement in how our services are delivered to allow these students to succeed. And then just implications of a college degree itself. We see that there's only a third of our students were able to a third of the college enrollees were able to successfully obtain their college degree. And it's important that we acknowledge how important a college degree is in life. Those who have a college degree are less likely to smoke. They're more likely to participate in community activities like volunteer work. They're more likely to vote. So it sets you up for a successful adult, employment and a successful life in a sense. So being able to, get our patients to that college degree is an important milestone. And then there's the idea of race. So in both the high school and the college group, and identifying as white was a significant predictor for a successful graduation. And that, plays into the historical, data that we have that the education system has been set up differently if you identify as white versus not white. So, this is just ongoing in the TBI population as well. So areas, so what can we do really with all of this information? It's important for us as clinicians and providers to be aware that there is a lag of care and obtaining a diploma in this population to be able to successfully or allow or set up our patients for success. And then when we look into in this research that we really only looked at internal factors, so personal factors as well as injury related factors that could be influencing graduation rates. But there's a slew of external factors that are also important, including financial support, family support, academic accommodations that we didn't really look at. So that would be an area that we could continue to look through the data to see if there are other predictors, external factors that are important for successful graduation. And then the GED versus the high school diploma. There's prior research in the general population that obtaining a GED is a different endeavor entirely than obtaining a high school diploma, and there are various things that go into reasons that go into why someone would obtain one versus the other. So looking into what the difference is in our TBI population that would lead someone to get a GED versus a high school diploma would be interesting to see as well. And then further looking into the interaction between race and education, specifically after a TBI, to really again set our patients up for success is an area that needs more research. So this project was done in conjunction with some folks in UT Southwestern. So I'd like to just acknowledge them, as well as my research mentors at JFK. And I'll take any questions.
Great job, Ashley.
Thank you.
We could, just for questions, maybe could we hold them to the end so we can move on to Nicole's talk?
Sure.
And then at the end, we'll so that if people have time to put questions into the Q&A, that'd be great.
Great.
Well, great. Our next speaker here in the research panel is Nicole Diaz-Segarra. She's going to present on, is there a role for botulinum toxin A in the management of post-traumatic headaches? Dr. Diaz-Segarra received her medical degree from Cooper Medical School of Rowan University and completed her physical medicine and rehabilitation training at Rutgers, New Jersey Medical School, Kessler Institute for Rehabilitation. She is currently the Brain Injury Medicine Fellow at Rutgers, New Jersey Medical School, Kessler Institute for Rehabilitation. Her specific areas are disorders of consciousness, spasticity, and neuropharmacology.
Thank you, Dr. Greenwald. Let me just share my screen and we'll get started. Okay. Okay. So thanks again for the introduction. My name is Nicole. I'm the current Brain Injury Medicine Fellow at Kessler. So let's get started with my presentation. So I have nothing to disclose. However, this talk does discuss the off-label or non-FDA approved use of medications. So here's a brief outline of what I'm going to cover in this presentation. So first, I will provide a brief introduction to post-traumatic headaches, discussing classification, pathophysiology, and current treatments. Next, I will discuss the currently published literature about botulinum toxin A treatment for chronic migraines and for post-traumatic headaches. And finally, I will discuss original research that's currently being performed at Kessler for the management of post-traumatic headaches with botulinum toxin A. So generally speaking, headaches are divided into primary and secondary. Primary headaches occur when there is no identifiable causative etiology. Some major types are migraine, tension, and cluster headaches. Secondary headaches occur due to an underlying condition or a specific event. And there are many different types, but for the purpose of this talk, the two major types for you to be aware of are post-traumatic headaches and whiplash-associated headaches. Headache types are defined by the International Classification of Headache Disorders, 3rd edition. Specifically, post-traumatic headaches are defined as having an onset within 7 days after head trauma or after regaining consciousness. It is considered acute when the headache has been present for less than 3 months and persistent when the headache has been present for more than 3 months. Post-traumatic headaches can be phenotypically characterized based on similarity to primary headaches, including migrainous tension or cluster. Whiplash-associated headaches, also referred to as cervicogenic headaches in the literature, can occur when there's a significant acceleration-deceleration force resulting in cervical injury with associated neck pain. So whiplash-associated headaches commonly occur in conjunction with post-traumatic headaches, and both types of headaches can stem from the same inciting event. Post-traumatic headaches are the most common physical complaint reported after a TBI, with a reported incidence ranging from 30 to 90%. Tension and migrainous are the two most common post-traumatic headache phenotypes that are encountered in clinical practice. So the majority of patients with post-traumatic headaches show improvement within the first 3 to 6 months after TBI. However, post-traumatic headaches are reported by 8 to 35% of patients at 1 year after their TBI, and 20 to 24% of patients at 2 to 4 years after the TBI. While post-traumatic headaches were originally thought to primarily occur after mild TBI, more recent evidence suggests that it commonly occurs after moderate as well as severe TBIs. So risk factors for developing post-traumatic headache include female gender and a premorbid history of headaches. Further complicating post-traumatic headaches is the presence of headaches itself interact with other TBI symptoms, including sleep disorders, affective and behavioral issues, as well as cognitive deficits. So based on this complex interaction, post-traumatic headaches can have significant negative impact on function and participation in work and social activities after a TBI. And up to 40 to 50% of patients with post-traumatic headaches report the post-traumatic headache having a significant negative impact on their functional status. So there are multiple potential headache sources or pain generators in the patient presenting with a post-traumatic headache. And they're broadly characterized into intracranial, cranial, and cervical sources. So briefly, intracranial sources can include the dura and venous sinuses. Cranial sources can include the skin, nerves, muscles, skull, and cranial cavities. And cervical sources can include joints, nerves, autonomic nervous system, and cervical neck musculature. So for example, there are multiple posterior neck muscles that are prone to develop trigger points, producing a referred pain that can contribute to headaches. So in the images to the right, you can see the headache referral patterns for the trapezius, semispinalis, and sternocleidomastoid muscles. The exact pathophysiology behind post-traumatic headaches is unclear, and there are multiple possible mechanisms at work. And this is well beyond the scope of this short presentation, but some proposed mechanisms include impaired descending modulation and afferent activation, neurometabolic changes, neuroinflammation through the release of pro-inflammatory mediators, and activation of the trigeminal sensory system through the release of nociceptive chemical mediators. Post-traumatic headache classification relies on a detailed history and physical exam, emphasizing the identification of pain generators to better guide management strategies. So as you can see to the image to the left, the treatment of post-traumatic headaches is often dictated by the phenotypic presentation and can consist of non-pharmacologic interventions such as manual therapy, physical therapy, or acupuncture, or it can consist of pharmacologic therapy with oral medications. Pharmacologic treatment can be further divided into abortive, which is treatment aimed at stopping the headache once it's started, and prophylactic, which is treatment aimed at preventing the headaches from starting. However, we're going to focus the remainder of the talk on one type of prophylactic treatment, botulinum toxin A. So what is the current evidence for the use of botulinum toxin A for the treatment of post-traumatic headaches? To tackle this question, we're first going to need to discuss botulinum toxin A use in the management of chronic migraines, which is a type of primary headache. So currently, onabotulinum toxin A, or Botox, is FDA approved for the prophylactic treatment of chronic migraines that do not improve with conservative treatment. So patients must be experiencing 15 headaches or more per month for greater than 3 months and have migrainous features on 8 or more of these days. So multiple studies were performed regarding the safety, dosage, and location for the treatment of chronic migraines with botulinum toxin A. The phase 3 research evaluating migraine prophylaxis therapy, referred to as PREEMPT, injection protocol evolves from these studies. So PREEMPT 1 and 2 studies were 2 separate phase 3 multi-center clinical trials that consisted of a 24-week double-blinded parallel group placebo-controlled phase followed by a 32-week open label phase. A total of 1,384 patients were enrolled with chronic migraines. In these studies, all patients received a minimum intramuscular dose of 155 units of onabotulinum toxin A administered at 31 injection sites across 7 head and neck muscles using what was called a fixed dose fixed site injection paradigm. In addition, up to 40 additional units of onabotulinum toxin A was administered into 8 additional injection sites across 3 head and neck muscles using what they call the follow the pain approach for a maximum total dose of 195 units. So just to explain that a little bit more, this is the fixed dose fixed site paradigm with 155 units administered across 7 muscles. So each injection site here gets 5 units of toxin. So the first image on the left shows the injection site for the corrugator at 1 site, procerus at 2 sites, and frontalis at a total of 4 sites. The second image shows where the injection occurs at the temporalis at 4 sites, with a total of 8 sites bilaterally. The third image shows where the injection occurs in the occipitalis at 6 sites. And the last image shows where the injection occurs in the cervicals paraspinals at 4 sites and trapezius at 6 sites bilaterally. So this is the optional follow the pain paradigm with an additional 40 units that could be injected into the areas of pain and maximal tenderness. So muscles that can be injected include the temporalis at 2 or less sites, occipitalis at 2 or less sites, and trapezius at 4 or less sites. So there were 2 main outcomes of the PREEMPT studies, including change in headache frequency and change in total headache days per month. So both preempt studies showed significant reductions in headache day frequency, while only preempt 2 showed a significant decrease in total headache days per month. So although the exact mechanism of botulinum toxin A in anti-nociception isn't fully understood, studies indicate that it may inhibit the release of nociceptive mediators such as glutamate, substance P, and calcitonin gene-related peptide from the peripheral nerves. Blocking the release of these neurotransmitters inhibits neurogenic inflammation and reduces the peripheral pain signals to the central nervous system. However, more research is needed to further clarify. So botulinum toxin A is not FDA approved for post-traumatic headache treatment, and the recommended dose and injection sites are based off of the preempt injection protocol for chronic migraines that I just discussed. The Ontario Neurotrauma Foundation's guideline for concussion and mild TBI state that when first, second, and third line oral prophylactic treatments fail, that onobotulinum toxin A injections up to 200 units every 3 months using the fixed dose to fixed site and the follow the pain preempt paradigm can be considered for the management of post-traumatic headaches. But besides these consensus guidelines, what published evidence is there for the use of botulinum toxin A for the management of post-traumatic headaches? So there's very little in the published literature and maybe a total of 4 or 5 studies. So we're going to discuss a few of them here. So these are 2 case reports. So Hobson in 1997 published a case of a 28-year-old female with a 5-year history of whiplash-associated headaches after a TBI who had a, quote, excellent response to 50 units of botulinum toxin A injected into the trapezius muscle at a trigger point. Repeat injections were required every 3 months to maintain her symptom relief. Another study was a case report by Leiper-Grunert in 2012. It was a case of a 62-year-old woman who presented with a 5-year history of persistent tension post-traumatic headaches after a severe TBI that did not respond to oral medication. They performed local injections, a total of 22 units of botulinum toxin A to the frontalis and corrugator muscles, and she experienced relief of the headaches within 5 days and complete resolution within 10. And so next, we're going to talk about a few larger studies that were done of varying design. So Freund in 2000 performed a randomized, double-blinded, placebo-controlled study using botulinum toxin A for the treatment of persistent whiplash-associated headaches. 14 patients received 20 units of botulinum toxin A injected into 5 cervical trigger points, and 12 patients received saline placebo injections. At 2 and 4 weeks post-injection, the botulinum toxin A group had significantly less pain and increased cervical range of motion compared to the placebo group. Finally, Yeri in 2015 performed a cohort study on 64 active military personnel with persistent post-traumatic headache after a mild TBI. So 40 patients received the FDA-approved chronic migraine fixed dose, fixed site paradigm, with the remaining receiving a combination of the fixed dose, fixed site and follow the pain protocol. The outcomes were global evaluation and headaches coded as better, no different, or worse. And overall, 64 of these patients reported feeling better. So there's very little, as you can see in the currently published literature, about the benefits of botulinum toxin A for post-traumatic headache treatment. So this brings us to the research that we're currently performing at Kessler. So we've clinically seen a positive result with the use of botulinum toxin A for the treatment of persistent post-traumatic headaches in the outpatient setting that are refractory conservative management. So in our study, we aimed to answer the following questions. First, is there a role for botulinum toxin A injections for the treatment of post-traumatic headache? This question would be addressed with the outcome measures including change in headache severity, change in headache days per month, self-reported change in headache medication intake, and changes in neck pain. And then finally, we were looking at the muscles that were injected, the doses of botulinum toxin A that were injected, and if there were any adverse events that were experienced. So we evaluated patients in a case series format in accordance with our IRB. We reviewed the charts of all patients that received botulinum toxin A for the management of post-traumatic headaches between January 2013 and December 2020 in the outsetting. In total, area consisted of 8 males and 5 females with ages ranging between 21 and 55 years of age. TBI severity based on GCS included 5 patients with a mild TBI, 3 patients with a moderate TBI, and 5 patients with severe TBI. All patients met the criteria for persistent post-traumatic headache and had minimal symptom improvement with physical therapy and oral headache medications. Headache characteristics included 3 tension-like and 10 migraine-like post-traumatic headaches, with 12 out of the 13 patients reporting a whiplash-associated headache component. So the mean time between TBI and the first injection was 22.8 months, ranging from 11 to 71 months. So out of the total 13 patients, 7 had sustained one or more of the following complications from their TBI, either a spinal fracture, temporal, occipital, or parietal bone fracture, and some type of surgical intervention for their TBI, either craniectomy, the cranioplasty, or craniotomy. And finally, the type of botulinum toxin A that was used for post-traumatic headaches management was selected at the discretion of the physician who initiated the treatment. 10 patients received oncobotulinum toxin A, and 2 patients received incobotulinum toxin A, with 1 patient receiving both over the duration of the treatment. So initial botulinum toxin A dosages ranged from 40 to 200 units total. Total doses were gradually increased in increments of 35 to 100 units based on patient response. Increases to each individual muscle varied, but did not exceed 10 units per muscle per injection. Maximum utilized dosages ranged from 90 to 600 units. Each injection was spaced 3 to 4 months apart. So on the chart to the right, you can see the starting dose for each patient in the middle column, and then the maximal dose that was achieved on the right column. So a total of 4 to 12 individual muscles were injected in each patient. Each muscle received 4 to 150 units. These muscles were selected based on a detailed headache history and physical exam. If the patient had undergone a craniectomy with a subsequent cranioplasty, the cranioplasty site was purposely avoided, even if it was part of their headache distribution. And in addition, for patients with VP shunts, the reservoir was identified and the catheter tracked along the neck musculature and eventually over the clavicle. And we specifically avoided muscles within close proximity to the catheter to avoid puncture. And again, even if these muscles were part of their headache distribution. So in total, there were 18 different muscles, the head and neck, that were injected. And just to go into this a little bit more detail. So all 7 muscles that are injected for the chronic migraine fixed dose fixed site protocol were injected in our study. And the 4 most commonly in our study were the temporalis, occipitalis, trapezialis, and frontalis, which were all sites that are injected in the fixed dose fixed site migraine paradigm. So less commonly injected muscles in our study from the fixed dose fixed site paradigm were procerus, cervical, spinalis, as well as corrugator. So the remaining 11 muscles that were injected in our study were not injected in the chronic migraine protocol. However, the majority of these muscles are targets for botulinum toxin A for the treatment of cervical dystonia or for cosmetic purposes. So these muscles included sternocleidomastoid, longissimus, levator scapulae, posterior scalene, splenius capitis, rhomboids, semispinalis, splenius cervicis, obliquus capitis inferior, orbicularis ori, and the epicranial aponeurosis. So this table shows the results of our primary and secondary outcomes for this case series. So first, I'm going to discuss the primary outcomes. So a paired samples t-test was performed on both primary outcome measures. There was a significant reduction in the number of headache days per month by an average of 18.1 days. There was also a significant reduction in pain ratings by a mean of 3.7 points. For both primary outcomes, the Cohen's d indicated a large effect size in the reduction of pain ratings as well as headache days. As for the secondary outcomes, 100% of patients who had whiplash-related headaches reported an improvement in neck pain, and 100% of patients were able to decrease their headache medication intake by at least 1. And finally, 12 patients continue to receive botulinum toxin injections to date. So there were a total of 3 reported adverse events. First, case 3 reported an allergic reaction that consisted of facial swelling and a rash after their 3rd injection with onobotulinum toxin A. She was then switched to incobotulinum toxin A, which also results in an allergic reaction, and therefore her treatment was terminated. So next, cases 1 and 5 reported transient neck muscle weakness with onobotulinum toxin A dosages that were greater than 400 units, and subsequent dosages were decreased to less than 400 units without recurrence of this adverse event. So now for a brief discussion. The multifactorial nature of post-traumatic headaches may not be addressed adequately with the current botulinum A treatment paradigms for chronic migraines. In addition to the 7 muscles in the injection paradigm for chronic migraine, we identified an additional 11 muscles that may benefit from being injected for post-traumatic headaches. The patients experienced that headache decreased pain severity, headache days per month, neck pain, as well as headache-related medication use. And interestingly, the patients in the study had variant TBI severity, and they all improved with these injections, suggesting that botulinum toxin A may be effective for post-traumatic headache management for mild, moderate, as well as severe TBIs. And while 3 patients had tension phenotypes and 10 had migraine phenotypes, 12 out of the 13 had whiplash-associated headaches. And it's possible that botulinum toxin A may help treat whiplash-associated headaches better than isolated post-traumatic headaches without that whiplash component. And the findings in the present study suggest the potential benefit also of individualizing the botulinum toxin A injection sites based on pain patterns, focusing on muscles within the headache pattern and utilizing a higher dose, and not using the cookie cutter pattern that you have in the chronic migraine protocol. Also, higher doses of botulinum toxin A were overall well tolerated. Therefore, doses of between 200 and 400 may warrant consideration in the future. And some limitations of the study include the retrospective nature, lack of control, small sample size, and the varying TBI severities. And also, since 12 patients had whiplash-associated headaches. So in conclusion, previously published findings together with the results of this present case series suggest a role for the treatment of post-traumatic headaches through an individualized approach with botulinum toxin A injections tailored to muscles in the headache pattern and cervical trigger points. We identified 11 additional muscles in addition to the 7 muscles that are injected in the preempt protocol. And doses between 200 and 400 units were well tolerated and warrant consideration for PTH management. And further studies are needed to clarify the efficacy and safety and tolerability of this personalized approach.
Great job, Nicole.
And just a quick thank you to Dr. JC, Dr. Debagian, and Dr. LaQuercia, who've helped me along with this. Thank you.
Great job, Nicole. I think I'm going to hold the end just to questions and answers till the end, and anybody can put that in the question answer box here at the bottom. Let's see, up next, let's see, we have Chris Schaub. Chris, are you there?
I'm here, Brian, thank you.
There we go. Let me introduce your talk. So Chris is going to talk today about promoting safe eating through the use of differential reinforcement and self-management and interdisciplinary approach. Chris has worked in post-acute brain injury rehabilitation since 1995 with a focus on neurobehavioral programming for individuals with all levels of neurologic impairment. After earning a master's degree in behavioral analysis from Temple University, he received his board certification in behavior analysis in 2004 and is currently a behavior analyst with ReMed, serving individuals with complex neurobehavioral needs. He presented at professional conferences in both the brain injury and behavioral analysis fields and has published on the application of behavioral analytic principles in brain injury rehabilitation. Chris co-authored the chapter on neurobehavioral complications for the current edition of the Essential Brain Injury Guide and serves as a subject matter expert for the Behavioral Analyst Certification Board in the area of brain injury. We'd like to welcome Chris for today's talk.
Thank you, Brian. All right. So good afternoon, everyone. I appreciate the opportunity to follow the physicians who presented wonderful talks. First, about all the statistical analysis and things going on with respect to transitioning in adolescence. And at ReMed, we serve adults from 18 and up. So we've certainly worked with folks in that age range who really struggle when those developmental milestones are missed due to traumatic brain injury. And I really appreciated the slide about Botox because as a behavior analyst, pain is a primary consideration with respect to behavior. and it can influence it quite a bit. And so a lot of the work that we do at REMED, and myself in particular as the behavior analyst, is in collaboration with our physicians and or other medical consultants in determining, to what extent certain variables are potentially unstable or requiring further treatment, so that behavior can stabilize and learning can occur. Because fundamental to sort of behavior as a behavior analyst is the process of learning. So having said that, I'm going to shift focus here a little bit into kind of single subject design from an experimental side of things, and talk about a particular case in which we used differential reinforcement and a self-management technique to teach safe eating to one of our brain injured individuals. And as Brian said, I work in post-acute residential brain injury. So we're talking about them, working in a house with maybe 8 to 10 individuals living in it, with various, severity in terms of their injury and various levels of time with respect to the time since they were injured. So I'm going to introduce my participant here and then talk about what we did. The other thing I want to highlight here is this interdisciplinary approach. And at REMED, we're fortunate. I'm fortunate to work in the settings I work in with OTs and PTs and speech therapists and TRs and psychologists and drug and alcohol counselors and neuropsychologists, and this great gaggle of folks that are highly invested in the work that we do and highly skilled at what they do. So any chance or need there is to collaborate, I take full advantage of. And we did so with this particular case. So before we'll do a little quick background in terms. Background information about our participant. It was a 31-year-old male, sustained a severe TBI in 2018 as a result of a work-related MVA. He was actually in a work truck that struck a pole and then a fence, and the fence came through the windshield. He sustained a significant brain injury and also had a penetration injury from one of the fence posts, which eliminated vision and made him blind in his right eye, and he had otherwise impaired vision in his left eye. He came to us 5 months post-injury. He was, pardon me one second here. Okay. He had 2 small kids at the time, which was a real shame. They were 4 and 6, because obviously he was requiring much more care that could be provided close to home. So he was a little bit of a distance from home. Sensory and visual issues factored into the decision-making process for the intervention I'll be describing. There were executive function issues with some affective instability and periods of tearfulness. Which I won't talk about today, but we collaborated with our neuropsychiatrist on some medication trials to try to mitigate some of those features and symptoms and help stabilize his mood and behavior. But that's a different talk for a different day. His communication was limited expressively, but generally was preserved on the receptive side, which was good. So we were able to kind of give, instructions or direction or commands, and he was able to follow them consistently 100%. Which was key because we were treating this dysphagia, which was fairly significant and required a modified diet of pureed foods and honey thickened liquids. And at the time in which he was referred for my services, so to speak, there had been an established pattern of unsafe eating and high risk for aspiration. So the intensive SLP intervention, which of course he got coming in the door and throughout the time that he was with us, that alone did not result in safer eating behavior. And as I said, impulsive eating persisted and eventually required one-to-one supervision for meals in a distraction-free environment in addition. So not only was it sort of a highly structured setting, but it was also, or situation rather, it was also one in which we had to kind of isolate for the meal because the distractibility during the meals became a primary feature of safety. In addition, the food prep, the puree, we're talking about a 31-year-old guy who had 2 small kids and was used to eating chicken nuggets and mac and cheese and pizza and cheesesteaks with his family. And now he was on a puree diet. So that significantly diminished his preference for foods. And his goal certainly was to have access to more preferred foods and normal textures. And one of the things that he identified was cheesesteaks, which I'm sort of a Philly kid. So I'm all about the cheesesteaks. So I was in his corner. Our goal was to establish self-feeding behavior that maintained safety and also promoted candidacy for higher preference foods at least a mechanical soft consistency. And there was also certainly a focus and goal on having him, reintegrate with his housemates during meals to socialize, which he enjoyed quite a bit. He enjoyed some of the camaraderie with some of the fellow residents and some of the banter that goes on during meal times. And then all the while, there was this ongoing collaboration with speech and language therapy to establish protocols and parameters for our intervention. I'm a behavior analyst, not a speech therapist, so we really needed her insight and expertise to kind of guide our procedure. And we also had the opportunity to collaborate with our OT to inform our intervention based on the visual deficits that were present for this individual. So there were quite a few sort of confounding, competing, and complex factors involved in this study or intervention, pardon me. Okay, so really quickly, I want to go over some behavior analytic terms. I don't have to worry about going over terms like dysphagia, tone, and spasticity for a brain injury audience, but I do want to just briefly talk about some behavior analytic terms that I'll be referencing as I review the data and graphs. So the first thing I want to describe is a procedure called differential reinforcement of low rates of behavior. And that's a procedure in which reinforcement is delivered contingent upon the number of target responses occurring at or below an established criteria. One example is, say, teachers in classrooms sometimes will use this type of procedure to kind of, diminish a little bit of like overeager hand raising. So you have a child that's raising their hand a lot. You might set a criteria at so many hand raises or fewer, accesses reinforcement. And it's a way to kind of reduce behavior. You can use it to eliminate behavior as well, but we used it just to reduce behavior with the goal of eliminating it eventually. But we knew at baseline the behavior was occurring at such a rate that we weren't going to be able to immediately eliminate it. And so we set out to use this DRL procedure, or differential reinforcement of low rates of behavior. The next is a DRI, which is known as differential reinforcement of incompatible behavior. And that's a procedure in which reinforcement is delivered contingent upon a target response that cannot be emitted simultaneously with the unwanted behavior. Another quick illustration is, again, teachers in classrooms. There's a lot of special ed teachers, out there that work with folks or kids or even regular ed classrooms that work with kids on in-seat behavior. So out-of-seat behavior would be a behavior that's incompatible with in-seat behavior, for example. And I'll describe in some level of detail how we use this DRI, or differential reinforcement of incompatible behavior procedure, with our fellow here. There's a concept of self-management, which I know it cuts across a lot of different disciplines, particularly in the brain injury world, because there's a lot of effort put into maximizing and optimizing folks' ability to be independent. And a large part of that has to do with safety and stability. And a lot of safety and stability is the result of self-management skills, or defined as an individual changes or monitors some aspect of their own behavior. And learn. And so again, in brain injury, with respect to awareness deficits, this capacity for self-management can run quite a gamut and span quite a spectrum. But it's if possible, it's always an ideal type of an intervention to teach someone to monitor their own behavior. In this case, we worked with this individual to monitor and regulate their own feeding behavior. And then last but not least, token economy. So token economy is a contingency package in which tokens are delivered contingent upon target responses and later exchanged for specific reinforcers. The reason token economies are so important is it allows you to deliver a reinforcer in the moment at the time of the occurrence of the behavior without it ultimately having to be the ultimate reinforcer. And for example, in our study, which I'll allude to and describe in detail momentarily, we used a preferred edible, a milkshake, as a reinforcer, and we were using that when he met criteria within the trial at the end of the trial. But each time he met criteria during the trial, we couldn't deliver a milkshake. That would be sort of unrealistic. So we set criteria using the DRL during the trial, and at the end we delivered tokens through the trial after each bite, and I'll describe what that means momentarily. And then at the end, he was able to cash in those tokens for these highly preferred reinforcers. So how does that go, and what does that look like? Let's talk about that. So through the data and graphs. So this first graph that we're looking at here was during our baseline phase, right? Which is where we established and assessed the baseline data related to the target behaviors, which were attempts to take another bite and mouth check accuracy. So we had this individual who during a meal, even with one-to-one supervision, would be set up with a plate with modified food and modified drink in front of him. And he would spoon rapidly and shovel, as I'm sure folks have seen in settings across the brain injury landscape. And oftentimes staff were required, would need to block him to try to, because he hadn't completely cleared his mouth of the previous bite. or they would have to move his plate away to stop him and prevent him from taking additional bites. And as I mentioned in the sort of background information, at the point at which I was involved, we were needing to have this meal in a quiet space, so there was less distraction, and it had to be a one-to-one facilitated meal because someone had to be there to intervene and block these attempts to bite. And so you can see during our baseline phase, and during baseline phase, myself or my colleague were seated with this individual during the meal, and also the speech therapist who participated in all these trials as a way to inform things like bolus size, technique, timing, those kinds of things. She participated in these trials as well. We made sure that, he wasn't able to take another bite in an unsafe way, and we just simply recorded an attempt, which you'll see in the top part of the graph there. The other thing that we did during those trials is after he took a bite and before he took his next bite, we would ask him if his mouth was clean. And we clearly talked about, and he was able to, we were able to confirm that he understood what we meant by clean mouth, meaning no debris in his mouth, and that he had swallowed the bolus of food sufficiently that he had taken. And so, there was under his tongue, and there was on his tongue, and there was sort of in his gums. And you can see the data there where we averaged the accuracy of mouth checks during the session, right, which we verified as we were there one-to-one in these sessions with him. And you can see the accuracy of his mouth checks was pretty significantly limited. Now, I mentioned in the background information there was a visual deficit and there was also a sensory deficit. We believe both of these things significantly affected his ability to detect debris in his mouth orally, whether that be visually or even with his fingers using that, or sensory wise, feeling some sort of sense of there's a pocket of food in his left cheek or his right cheek or his gum or some area like that under his tongue. And he was limited in his ability to do that. And so we weren't surprised by those mouth check accuracy data. But we were also, at the same time, we were concerned about the attempts to take another bite, because that was one of the most unsafe features of the meals. So at the bottom of that far right box, you'll see we also conducted what's called a preference assessment. And a preference assessment is a tool that behavior analysts use to establish a hierarchy of preferences. We interview folks, we interview staff, we ask them what they like, and for the particular purposes of this case, we were talking about consumables that could be delivered at the end of a meal. If criteria were met. And so we interviewed the individual as well as some of the staff they worked with and some of the foods he liked and the foods they prepared. And we came up with, and then we present those things in pairs, and the individual chooses. And it's a systematic way to arrive at a hierarchy of preference versus just asking someone and assuming that they like what they said they asked for or told you that they liked. In behavior analysis, we experimentally and systematically test that out. So the number one out of, say, 6 or 8 items, I forget the total number of items, but the number one item was a strawberry milkshake, and the chocolate milkshake was a close second. So we utilize those as we move forward here in the reinforcement phase of the plan. Okay, so you'll see at the top, what we did was there's that solid line, which indicates that we started an intervention, and that intervention was the DRL plus the TE, so that's differential reinforcement of low rates of behavior. And the TE is the token economy. Okay, so we introduced criteria for how many bites to take, and we also introduced a timer. So what we did was we addressed the high-risk behavior of attempts to take another bite. We really needed them to slow down. So with the DRL rather, and the TE, we set a timer for 30 seconds, and if no bites were attempted within that time, a token was earned. And tokens earned during the meal were exchangeable for a milkshake. So we had a criteria of how many tokens to earn to access the milkshake. And at the end, if he had that many tokens, then he was able to exchange them for the preferred milkshake. And as you can see, the DRL and TE significantly and rapidly reduced attempts to take another bite. And we believe that was a feature of the timer, and certainly, first and foremost, a feature of the impact of the contingency. As a behavior analyst, we're firm believers in, consequences govern behavior. And in this case, making some reinforcement available for this individual really helped reduce rates of very unsafe behavior. And as it says there in the third arrow on the far right, we did tweak. This gave us an opportunity also to tweak our procedure with speech therapist input. And again, you'll see at the bottom, although that graph extends, we did not apply the intervention to mouth check accuracy. So you see that still hovers somewhere between, mid 40s and potentially as high as 80%, but highly variable. In phase 2, we introduced the self-management technique, or tool rather, which was a mirror. So this was like a magnified makeup mirror that we could actually affix to the table, like a suction bottom. So we had the plate, the individual had a utensil and a cup, and then they had the makeup mirror, and we had to be very careful in how we positioned that due to his visual deficits. And so, we placed the mirror in such a way that he could turn his head, he could open his mouth, and with his preserved vision, he was able to utilize the mirror as a way to do mouth self-checks. Now, we still had to verify these, but as you can see, his accuracy went from, variable, maybe an average of in the 40s, perhaps, up to 80% and above. And so we faded the timer, and the tokens were now earned for no attempts prior to mouth checks and accurate self-checks, mouth self-checks. So again, we started with this original different DRL and token economy, a timer, and just trying to slow things down. When we introduced the mirror, we then said, before you take a bite of food, before you take your next bite, you have to do a mouth check, and we track the accuracy of that mouth check. And accuracy went up, especially when we added the reinforcement to it in the mirror. So that was a really encouraging finding. Now, what you'll see, however, is that attempts to take another bite rose slightly, which was a big red flag for us. That was not a change or an increase that we were able to tolerate, because coming out of the gate, that was the highest priority, was this rapid eating or the shoving behavior, and we knew that was problematic and challenging. And so we started to talk about modifying the intervention. We created a behavior chain using the utensil and the mirror, and what the behavior chain looked like was, pick up utensil, take a bite, put down the utensil, chew, check, pick up once, mouth clear, pick up the utensil, take another bite. And so this is where we shifted from that DRL with the timer, right, and the self-feeding, the attempts to take another bite, to this DRI. So the incompatible behavior that we reinforced was putting the utensil down after he took his first bite. So we would take a bite of food, and as long as he put the utensil down, he still earned a token for that. And then if he had an accurate self-check, he earned a token for that. So we switched our differential reinforcement procedure a little bit, and this was much safer and led to fewer issues. Now, meanwhile, in another part of the world, baclofen was increased to address tone and spasticity that this individual was dealing with in a chronic way. And that significantly impacted oral motor function. So at this point, not only were we collaborating with the speech therapist and the OT, but we now were talking to the physiatrist that consults with us once a week in-house about the effects of baclofen in swallowing. And actually, they're not displayed here, but we had data on intervals of chewing in between bites, which turned out to correlate with the change in the medications. And so, for example, they went up when the increase occurred. So it took him longer to chew his food, and that's where some of those concerns came. So the nice thing was, not only were we sort of directly tied into OT and PT, or OT and speech rather, but we linked in with physiatry and used these data to guide this baclofen trial. Now in phase 3, the baclofen was reduced because it was having this deleterious effect, and it wasn't having the intended effect on the other muscles that it was targeting. And trials were put on hold, and the baclofen was decreased. So we used time to chew data as a measure for when we returned to baseline, obviously, as well as our speech therapist evaluation. And then when we reintroduced the procedure, this is where we added the DRI component that I mentioned. So what you'll see is in that on the top side, on the far right slot, DRI plus TE plus mirror, we got attempts to take another bite down to 0. It eliminated attempts to bite because we were now reinforcing an incompatible behavior. So this switch from DRL to DRI turned out to be the right move because it eliminated that behavior. And the accuracy of self-mouth checks was maintained at high levels, which we were really excited about. And then lastly, in phase 4, we faded our reinforcement procedure because trials of mechanical soft foods were on the horizon. He was now eating in a more paced, safe way. The baclofen issue had been resolved, and his mouth checks were more accurate, as you can see in the data. And so the speech therapist felt like it was appropriate for us to begin to, at some point, introduce mechanical soft foods. So we were able to fade the arbitrary reinforcer of the tokens in the milkshakes because it was now moving towards this much more powerful and sustainable natural reinforcer of, the mechanical soft foods. So the DRI successfully established incompatible behavior. The mirror continued to be used as an effective self-management tool, although we continued to need staff verification. The BCBA and the speech therapist finalized the protocol and introduced additional staff members. So we had this protocol nice and tight amongst a few of us. Now we needed to generalize this across other staff members and teach to other team members and how to support the meal using this intervention. And then we generalized the protocol to back into the dining room. So stabilize the behavior, finalize the intervention through a refinement process, taught it to other staff, and then moved it to a different setting. So all of a sudden, we now have him eating with more people and back in the dining room. And the best part was he had himself some cheesesteak with the speech therapist. And that was the big happy ending to this whole thing. So I want to thank you for this opportunity to talk a little bit about behavior analysis and the work we do in brain injury and this discussion about dysphagia. Thank you so much.
Great presentation, Chris. Thank you so much.
And we have 10 minutes for questions now. I'm sorry, Dr. Greenwald, you can continue. That was just the 10-minute warning.
Okay, thanks. So I was just like yourself, just encouraging people if they have questions to put them in the Q&A section here or the chat section. So I see the first question here. Have any publications translated your research language that is accessible for consumers and families? I think currently the research is still sort of in the pre-publication phase. Chris, did you publish your research yet? This interesting case.
No, we've not, Brian. No, we haven't. But it's not uncommon for some of the technical language to be distilled into a procedure that's in, fairly accessible and understandable terms. So if, for example, like when we taught the other staff, I wasn't using all the terms that I was using during the discussion. We were just talking about, when this happens, do this, or when this happens, do that, and made it sort of straightforward to follow.
Try. I know I do a lot of work with the model systems and the knowledge translation, taking things and make them as simple as possible, for people to sort of translate the good research that we're doing so that families and survivors could understand it better. And then, of course, making sure that it's accessible to other clinicians also. Well, if there's no other questions, I want to thank everybody for attending these excellent lectures. And thank you so much for the speakers for coming today and presenting on these interesting topics. Thank you so much.
Thank you, Brian. Thank you, everyone.